to the
This
demo.
was really good. Amara is 17 years old, originally from Ghana, where she lived close to Lake Volta. Occasionally reported of mild dyspnea and palpitation, but nothing really in particular. Then her parents moved to Austria because they work for an international organization and took Amara with her. Only 2 months later, she developed a stroke. So she has a neurologic problem. But why? To find out, we have to look at the echocardiogram. This is her parasternal long axis view. Well, her left ventricle function is completely normal. The aortic valve opens completely normal. The problem here, however, is the mitral valve. It does not open normally. This patient has mitral stenosis. There is obstruction to inflow, as you can see right here at the mitral valve. Here is an autopsy specimen of a patient with mitral stenosis. What do we see? Well, the mitral valve is massively thickened, and the opening is reduced. We only see a little slit here, as a matter of fact. Why does someone get mitral stenosis? Because he gets rheumatic fever. And rheumatic fever is the result of a bacterial infection with beta hemolytic streptococcal bacteria, and they produce a toxin. And this toxin causes damage to connective tissue and damages certain organ systems, namely the joints, the brain, and the heart. If you look at the heart, it's not only the mitral valve which is affected, but very frequently also the aortic valve. Here you see calcification and fibrosis of the aortic valve. Remember, in the third chapter, which dealt with the mitral valve, and also in the sections where we showed you how to image, we talked about the normal motion of the mitral valve. You see that the anterior and the posterior leaflet coapt actually along a certain surface here. And you can imagine that if you have just a little bit of leaflet retraction or tension on the leaflets or a part of the leaflet which is ruptured, you can easily get significant mitral regurgitation. You can appreciate how delicate these chordae are when you look at the mitral valve now from the ventricular side. Here, this is the papillary muscle, and right here you would see the chordal structures, which are actually relatively resistant, very strong, but still under certain conditions they can rupture, as you will see in a few examples that we're going to present to you during this lecture.
But now our focus is on the mitral valve. So we can see actually the mitral valve is really opening during diastole and closing during systole. I think it's a normal valve. What do you say, Thomas?
Yes, it's an absolutely normal valve. We have the anterior leaflet right here, which is closer to the transducer and closer to the aortic valve. Then we have the posterior leaflet, which coapts with the anterior leaflet right here.
This is really nice to see. Again, the mitral valve on the left.
Yes, you see the anterior leaflet, which is a bit longer, and the posterior, which is a little bit shorter. Let me show you this. Here, this is the anterior leaflet. This is the posterior leaflet.
Yes.
Compare this parasternal long axis view with this one right here of our patient. Do you see the difference? Well, it's very simple to see the difference if you freeze the image and look at the position of the mitral valve. The mitral valve shows what we call doming. In other words, it does not completely open. This is the hallmark of mitral stenosis. Again, a short review. Here is a normal opening excursion of a normal patient. You see the mitral valve is closed, then it starts to open, and during end diastole, it almost touches the interventricular septum. What about our patient from Ghana? It looks completely different here. The valve is closed, it's starting to open, but still the tip of the leaflet is pointing towards the posterior leaflet. This is the doming. You can easily appreciate doming of the mitral valve also with three-dimensional imaging. Just to demonstrate what happens, here we have the mitral valve. You can see that this anterior leaflet here actually domes right here. This would be the left ventricular outflow tract. This is the posterior leaflet here. And this little black portion here is the opening. Again, doming in the 2D image, and here in the 3D image. The degree of doming can vary greatly depending on how pliable the leaflets are. And in addition to the presence of doming, we frequently see other findings, such as thickened leaflet tips, right here, and a thickened subvalvular apparatus, the chordae. In addition, look for an enlarged left atrium, and also focus on the aortic valve, because remember, the aortic valve can also be affected in rheumatic heart disease. And what about this patient? Does she have mitral stenosis? Well, the opening of the mitral valve is rather poor. The leaflets hardly move. And certainly, we can see that there is little separation between the two leaflets. And we can also note that there's a large distance between the tip of the anterior leaflet and the septum. But is this really rheumatic heart disease, mitral stenosis? No. What this patient has is dilated cardiomyopathy. Left ventricular function is very poor. And the reason why the valve doesn't open is because it's not being pushed open, because cardiac output is low. So don't confuse this pathology with rheumatic mitral stenosis. Here's how the mitral valve looks in a short axis view. What do we see? Well, we have a valve where the commissures are fused right here and right here. This leaves a rather round opening. This does not mean that all patients with mitral stenosis have a round opening, but essentially you will find commissural fusion in all patients. What is left now is an opening which is stenotic, and you can actually trace the opening here and calculate the mitral opening area. This is something you certainly would not need to do in an emergency setting, but something that we'll talk about in more detail in our masterclass. Here's an example to show you that mitral stenosis can also be visualized with transesophageal echocardiography. Again, we have the typical features of a thickened tip of the mitral leaflet, doming, and obstruction to inflow. An example of a parasternal long axis view again. Again, I think now you can easily make the diagnosis already. This is mitral stenosis. But in addition, we see that the aortic valve is also calcified and severely thickened. Why is that so? Well, because, as I mentioned previously, patients with rheumatic heart disease also have aortic valve involvement. So check for aortic regurgitation and check for aortic stenosis in these patients as well. Apical long axis view, again, classic doming. In this view, you will frequently be able to visualize the subvalvular apparatus and see the thickening of the cords. In this view, you can appreciate the other additional findings we're confronted with, namely a large left atrium, and in this case, we have atrial fibrillation, a frequent finding in patients with mitral stenosis. Now, not all patients, as I mentioned previously, have such a classic, wonderful doming. Some patients, especially when they get old, develop calcification of the leaflets, and then they lose some of the doming, and then the diagnosis might be a little bit more tricky or difficult. Here is such a patient, an 86-year-old woman who had long-standing mitral stenosis, and the valve is now thickened and calcified, and you can hardly appreciate that there is some doming here. The left atrium is, as a matter of fact, very, very large. Now, what do you do if you have very poor image quality and you cannot really see the mitral valve? In such a setting, what you can use is color Doppler because it helps you to visualize the obstruction to inflow. This is a phenomenon we also call the candle flame phenomenon, because the jet which enters the left ventricle looks very much like a candle flame with high velocity colors or shades in the center of the jet. Look at that again. Here's such a patient. You have flow convergence right below the mitral valve, and then this typical candle flame appearance. So use color if you are not sure, and it sometimes can point to the diagnosis of mitral stenosis if you're not able to visualize the valve otherwise. As a matter of fact, this is our patient Amara. Now that we know that there is mitral stenosis and flow acceleration, we want to know more about the velocity across the valve, because similar to aortic stenosis, it will allow us to quantify the severity. What do we look for? Well, the first thing we will note is that the velocity is elevated. We have a velocity somewhere in the range of 2.2 meters, and that the spectrum never really reaches the zero line. This is an indicator that there is stenosis, but is it severe or not? To find out, I want to show you first a normal mitral valve spectrum where we see the typical features of the E wave and the A wave and a very steep deceleration which almost reaches the zero line, and compare it to the patient here. Obviously the sweep speed is a little bit different here, so you cannot directly compare it, but nevertheless the shape looks completely different. What about this spectrum here? In a different patient, something is missing here. It is the A wave. The patient does not have a second wave towards the end of diastole, and the reason is clear, because this patient, as you can see in the ECG, does not have a P wave. This is atrial fibrillation. So the spectrum of mitral stenosis looks quite different in patients with sinus rhythm opposed to atrial fibrillation. If we now record such a spectrum, we want to quantify the severity of mitral stenosis. And we do this by looking at, again, the gradients. And as with aortic stenosis, we can measure both the maximum and the mean gradients. Let's do this now in our patient. So we trace the spectrum, and we get a mean velocity, which can then be translated into a mean gradient. In our case, the mean gradient was 40 millimeters of mercury. How does that compare to the severity? Here is the grading scale. Below 8 would be mild, between 8 to 15 is moderate, and above 15 is severe. So we're somewhere in the range of a moderate, almost moderate to severe mitral stenosis. As promised, I will now come back to Amara and solve the case. Here are the apical long axis views in 2D and in color. What do we see? Well, first of all, again, the typical features of doming and the candle flame, the accelerated flow. A little bit of mitral regurgitation is seen here as well. Now, why did this patient develop a stroke? The reason is very simple. For one, patients with mitral stenosis are prone to develop atrial fibrillation. Maybe this patient did have intermittent atrial fibrillation. And this atrial fibrillation, as well as the stenosis, causes slow flow in the usually enlarged left atrium. And what can come out of it is shown here on this transesophageal echo. A large left atrium with spontaneous contrast in a patient with mitral stenosis, and as a result, there's thrombus formation here in the left atrial appendage. I guess it's all clear now. The suspicion is very high that she developed a thrombus which dislodged and caused her stroke. This is from an interesting study that was performed in 12 African countries and the addition of Yemen and India, where they looked at patients with mitral stenosis and why they came to an emergency department. Altogether, they looked at over 3,000 patients, and what they found was that the majority came with congestive heart failure, followed by pulmonary hypertension, atrial fibrillation, stroke, endocarditis, and bleeding. So here we have all the typical complications that you have to be aware of in patients with mitral stenosis. Why do they develop them? Well, congestive heart failure, because they have elevated pressures in the left atrium, which translates to pulmonic circulation, and then further to the right ventricle, causing pulmonic hypertension. Atrial fibrillation for the reason I just showed you in our patient. Same as stroke. Endocarditis, because patients frequently get bacterial infections on the mitral valve lesion. In other words, mitral stenosis is a predisposing factor for endocarditis. And finally, bleeding, because patients who are in mitral stenosis are frequently anticoagulated. You have to know that patients with mitral stenosis can develop pulmonary edema very, very quickly. It can go within minutes. And the reason is, as I mentioned previously, that the obstruction to inflow causes elevation of left atrial pressure. Here you see that the left atrium is very large, and it translates to the pulmonic circulation. Okay, so this concludes the chapter on mitral stenosis. As a take-home message, just remember that patients with mitral stenosis are frequently found in developing countries where antibiotics have not been given to prevent rheumatic heart disease. It's a disease that you see in the young, and it is more frequent in females than in males. It has a high rate of cardiovascular complications, and the typical feature is that of doming of the anterior mitral valve leaflet with a rather small left ventricle, large left atrium, and the severity can be quantified with the help of Doppler. You look at the maximum, but even more so the mean gradients. But what happened to Amara? She was lucky because her stroke was small and she recovered quickly. Now she's waiting to get mitral valve valvuloplasty done to treat her mitral stenosis. This ends the chapter on mitral stenosis, but we're not done with the mitral valve yet, because in the next section we'll talk about the other lesion of the mitral valve, mitral regurgitation.